Okay, let's unpack this. We are diving into the complex, often tragic, world of substance misuse, a topic that, well, it touches virtually every corner of human existence and presents a really profound challenge to modern medicine.
Absolutely. And, we're not just scratching the surface today. Our mission here is to really master the underlying pharmacology, the precise chemical mechanisms, the clinical signs you see, and, importantly, the advanced pharmacological treatments for common drugs of abuse.
Right, think of it like building that professional toolkit, getting the knowledge you need to truly understand this field at a deep level.
Exactly. And the source material really grounds this immediately, doesn't it? With those vignettes.
Yeah, they're quite powerful. You've got the young boy inhaling paint fumes, maybe for a fleeting escape, the gang member smoking crack, perhaps seeking some kind of belonging.
Then there's the college student trying Molly, maybe out of curiosity,
hmm
the lonely widower turning to bourbon, and that really tragic example of someone injecting fentanyl-laced heroin.
In every single one of those cases, you see chemicals being used for reasons that are profoundly non-therapeutic. And that, right there, defines our core subject, substance misuse.
And when that misuse becomes compulsive or starts harming the person's physical or mental health, that's when we start talking about a substance use disorder.
We really need to get a handle on the scale of this, too, the numbers. They paint a pretty stark picture of a crisis.
They really do. If you look at the U.S. data from around 2015, something like 10.1% of the population were current users of illicit substances. That's huge.
Massive. And that's not all, is it?
No. On top of that, you had about 6.2% with an alcohol use disorder and another 4.7% misusing prescription meds. So, these aren't fringe issues. They're absolutely core public health crises.
And the trend seems to be heading towards even greater danger, unfortunately.
That's a critical point. The substances people are abusing now are often significantly more potent than they used to be, and the ways they're administered, like smoking or injection, are just much more effective at delivering that hit quickly.
Which ramps up the risk, doesn't it? Both for getting addicted fast and for acute toxicity.
Absolutely, it's a dangerous combination. So where should we start? Maybe with the stimulants.
Yeah, let's start there. The most explosive class, perhaps? The sympathomimetics? That seems like the perfect place to begin.
Okay, section 1 it is. We're focusing on agents that basically push the body into a state of almost constant fight or flight.
So these are the stimulants, right? They mimic the sympathetic nervous system. What's actually happening mechanistically at the synapse level?
Fundamentally, what they do is produce a relative increase of adrenergic neurotransmitters.
Yeah.
We're talking specifically norepinephrine, epinephrine, and dopamine. Right there, the sites of action.
And that flood of neurotransmitters causes those classic symptoms we see in the ER.
Exactly. That's the toxidrome. Tachycardia, so a really rapid heart rate, hypertension, high blood pressure, hyperthermia, which is that dangerous elevated body temperature, and tachypnea, rapid breathing. That cluster of signs point strongly towards sympathomimetic toxicity.
But it's not just the physical stimulation, is it? Their power to addict is just immense. Where does that piece come from?
That's where it gets really key for understanding, for mastery. There's this incredibly powerful link between the stimulation they cause and the production of intense pleasure. Specifically, it's that massive surge of dopamine in the brain's reward circuits.
The pleasure center.
Precisely. That powerful euphoria is the absolute core driver of the compulsive behavior, the seeking of the drug again and again. It makes these drugs highly addictive. And, well, it fuels the enormous profit motive in the illicit drug trade, too.
Okay, let's use that framework. Let's dive into cocaine. It comes from the coca shrub, native to the Andes. Its pharmacology seems like a perfect illustration of this mechanism.
It really is. It's almost elegant in its simplicity and its brutality, pharmacologically speaking. Cocaine causes profound CNS stimulation, the central nervous system, mainly by inhibiting the reuptake of norepinephrine back into the adrenergic nerve terminal.
So the norepinephrine just hangs around longer.
Exactly. It stays in the synapse longer, activating the receptors over and over again. More bang for your buck neurotransmitter-wise.
But focusing on the addiction specifically, it's not just about norepinephrine, is it?
Oh, absolutely not. The really profound, that immediate, almost irresistible addictive lure stems from its effect on the pleasure centers, the nucleus accumbens in the brain. And that's primarily achieved through the powerful inhibition of the reuptake of dopamine.
Dopamine, the key player.
The key player for addiction, yes. And also serotonin reuptake is inhibited, though maybe to a lesser extent. But it's that intense, immediate dopamine surge that forms the pharmacological bedrock of cocaine's addictive potential.
Right. Now let's link that mechanism to how it's used, the administration routes and how that drives the addiction dynamics. You've got cocaine hydrochloride, the powder form, people snort it or inject it, but smoking that form doesn't really work, does it?
No, it degrades with heat. And that's why the development of crack cocaine, the alkaloidal or freebase form, was such a devastating step, pharmacologically, for the illicit market. Because it's chemically modified, it can be smoked.
And smoking is incredibly effective.
Extremely effective, because your lungs have this huge surface area. They're highly vascularized, just packed with blood vessels. So the drug gets absorbed almost instantaneously and travels straight to the brain. That's what causes that incredibly intense euphoria, what users call the rush.
But the high comes on so fast, and then the drop-off, the crash, is just as quick and severe.
Exactly. And it's this pharmacokinetic profile, that wrap it up, wrap it down, that makes it so incredibly pernicious, so addictive. You get this immediate, powerful, positive reinforcement, the rush.
It makes you feel amazing.
Right. But it's followed almost immediately by this intense dysphoria, this awful feeling, the crash. That's powerful negative reinforcement. So the user instinctively wants to take more drug to get rid of that crash feeling.
Starting the cycle all over again.
Precisely. Often needing to use repeatedly in a very short time frame. And we also have to remember, street cocaine, crack, it's almost never pure. To increase the bulk and make more profit, dealers cut it, they adulterate it with cheaper substances, and that adds all sorts of unpredictable risks and toxicities.
Okay, let's shift to the clinical side, the crisis point in the emergency room. Toxicity and treatment. What do cocaine users typically present with?
Usually a range, but common presentations include psychiatric complaints, severe agitation, paranoia, sometimes profound depression, convulsions or seizures are a major risk, chest pain is very common, mimicking a heart attack, and then there's the really life-threatening one, hyperthermia.
Hyperthermia, you mentioned that earlier. Why is it so dangerous with cocaine?
It's often cited as the #1 cause of cocaine-related fatalities. And understanding the mechanism here is absolutely key for professional management, for mastery. The danger comes from this nasty dual physiological problem.
Okay, break that down.
Right. First, the intense CNS stimulation caused by the cocaine dramatically cranks up the body's metabolic rate. So consequently, you're producing a lot more heat internally.
Okay, increased heat production. What's the second part?
The second part is that cocaine is a potent vasoconstrictor. It clamps down on blood vessels, especially in the skin and periphery. And that clamping down severely limits the body's ability to dissipate the heat it's generating.
Ah, so you're making more heat and you can't get rid of it.
Exactly. The patient is rapidly generating heat while simultaneously trapping it inside their body. It's a physiological nightmare, and core body temperature can skyrocket very, very quickly.
And separate from the temperature, there's also direct damage to the heart, the cardiotoxicity.
Yes, absolutely. Cocaine causes coronary artery vasoconstriction. It tightens the artery supplying the heart muscle, starving it of oxygen. This can trigger heart attacks, even in young people. Plus, it actually accelerates the atherosclerotic process, the buildup of plaque in the arteries.
So users are at higher risk for heart attacks and strokes much earlier in life.
Much earlier, alarmingly so.
And here's a crucial interaction. The danger gets even worse when people mix cocaine with alcohol.
Ah, yes, the polysubstance issue. When ethanol and cocaine are consumed together, the body actually metabolizes them to create a new secondary metabolite,
Godsappow?
cocaethylene.
Yeah.
And this compound, cocaethylene, is significantly cardiotoxic itself. It really contributes heavily to the heart problems we see.
So it's not just the cocaine, it's this extra metabolite too.
Exactly. And here's a really important clinical insight for you, something for that mastery level. The half-life of cocaine itself is relatively short, often less than an hour. So that intense rush fades fairly quickly.
Okay.
But the half-life of cocaethylene is much longer, often 2 to 3 hours, maybe even more. This means the cardiotoxic stress on the heart, caused by cocaethylene, is prolonged long after the initial cocaine high is worn off. This is absolutely crucial for predicting clinical outcomes and understanding why these patients can suddenly deteriorate hours later.
Wow, that dramatically compounds the risk. So given all this, the agitation, seizures, hyperthermia, cardiotoxicity, what's the core treatment strategy in the ER?
It boils down to 2 words: calming and cooling.
Calming and cooling, okay.
Precisely. The absolute mainstay of treatment, The first-line agent is benzodiazepines, something like lorazepam or diazepam. They serve multiple critical functions.
Like what?
Well, first, they calm that profound agitation and paranoia. Second, they're excellent at preventing and treating the convulsions or seizures.
Yeah.
And third, and this is vital for the hyperthermia, the calming effect reduces excessive muscle movement like shivering or thrashing, which helps the body stop generating so much extra heat.
So the benzos help with cooling indirectly by reducing heat production.
Exactly. Beyond the benzos, the rest of the care is largely supportive, managing the high blood pressure, actively cooling the patient if needed, monitoring the heart.
Okay, that makes sense. Let's move on to some other sympathomimetics. Amphetamines, particularly methamphetamine. You said the clinical picture is similar to cocaine, but there's a subtle difference in the mechanism.
Right. They definitely share many clinical effects that sustain stimulation, the alertness, the potential for toxicity. But amphetamines primarily work by enhancing the physical release of those biogenic amines, the catecholamines, directly from their storage sites within the nerve terminals.
So instead of just blocking the vacuum cleaner reuptake, they're actively pushing more neurotransmitter out.
That's a great analogy. They're forcing more out into the synapse rather than just stopping it from being cleaned up. Because this release can be quite sustained, amphetamines often last longer than cocaine. They might cause more generalized stimulation, perhaps slightly less of that intense initial euphoric rush compared to crack cocaine, but a longer-lasting high.
Got it. Okay, next up, MDMA, known as ecstasy or Molly. The source material calls it a hallucinogenic amphetamine. This one seems to shift the focus towards serotonin, doesn't it?
Very much so. MDMA has really profound and quite complex serotonin-releasing effects. It does several things at once. It causes a massive release of serotonin into the synaptic cleft. It inhibits the synthesis of new serotonin, and it blocks serotonin's reuptake.
Wow, so it hits serotonin from multiple angles.
It does. The net result is this explosive increase in serotonin concentration in the synapse, which is thought to mediate that initial high. But the dangerous flip side is that this process leads to a serious depletion of the serotonin stores inside the neurons afterwards.
And this unique mechanism is why it gets called an empathogen, that feeling of well-being, social connection.
That's the idea. Users report feeling intense well-being, heightened empathy, increased social interactivity. Tactile stimulation, touch, can also become intensely pleasurable.
But the adverse effects are pretty specific and can be really dangerous.
Highly specific, yes. Because of that excessive release of monoamines, MDMA is notorious for causing bruxism, that's involuntary teeth grinding, and trismus, which is jaw clenching.
Ah, so that's the reason behind the pacifiers and lollipops you sometimes see associated with rave culture.
That's the physiological origin, exactly. It helps manage those jaw effects. But far more critically, MDMA has a high propensity to cause profound hyperthermia, just like cocaine, but sometimes even more severe, altered mental status, and potentially life-threatening serotonin syndrome.
Serotonin syndrome, that sounds serious. What does that involve?
It's a true medical emergency. It's characterized by a triad of symptoms: severe changes in mental status, agitation, confusion, coma, autonomic instability, wild swings in heart rate and blood pressure, fever, and neuromuscular hyperactivity, muscle rigidity, tremors, hyperreflexia, clonus.
Okay, so how do we treat MDMA toxicity, especially that dangerous hyperthermia?
Again, benzodiazepines are absolutely essential for the calming and cooling aspects, managing agitation and muscle activity. But the extreme heat generated by MDMA, especially if someone's been, say, dancing for hours in a hot, crowded club, it could be incredibly severe.
So benzos might not be enough.
Sometimes, standard cooling measures, ice packs, fans, cooling blankets combined with benzos, just aren't fast enough if the core temperature is dangerously high, like over 105, 106 degrees Fahrenheit. In those life-threatening situations, we sometimes have to resort to the most aggressive measure available.
Which is?
We have to use neuromuscular blockers, drugs that cause complete muscle paralysis, and perform endotracheal intubation to control their breathing.
You paralyze the patient?
Yes, because by chemically paralyzing them, you stop all muscle movement, including shivering, and that immediately halts the body's excessive internal heat generation. It's often the only way to rapidly gain control of life-threatening hyperthermia in these extreme cases.
Wow, that's a critical piece of clinical knowledge right there. Sometimes you have to completely shut down the body's heat engine to save the brain.
Absolutely. It's an extreme measure for an extreme situation. Now, for the serotonin syndrome itself, the specific antidote is a serotonin antagonist called cyproheptadine.
Cyproheptadine. Does it work well?
It can be helpful, but its utility is unfortunately limited because it's currently only available as an oral tablet or syrup. And trying to get an oral medication into someone who is severely agitated, maybe seizing, or has profound altered mental status, it's often just not feasible or effective quickly enough.
Right, that makes sense. And like cocaine, the risk of adulteration, of getting something other than what you think you're getting, is really high with MDMA, isn't it? Especially with methadone.
Extremely high and particularly insidious. Methadone is often substituted for MDMA, and the reason is purely profit. Chemically, it's very similar, differs by just one small carbonyl group, which makes it relatively easy to synthesize and pass off as MDMA.
But the effects aren't the same.
No. It's generally considered less euphoric, and crucially, it often has unpredictable and potentially more severe toxic effects. So the user thinks they're taking Molly, but they're actually getting something potentially more dangerous, increasing the risk significantly.
Okay, one more in the stimulant category before we move on. The synthetic cathinones, which burst onto the scene as bath salts.
Ah, yes, the bath salts. These are synthetic derivatives of cathinone, which is the psychoactive component found naturally in the khat shrub. But the synthetics, things like methcathinone, mephedrone, MDPV, butylone, are far, far more potent.
And the bath salt's name was just a disguise, right?
Completely deceptive packaging. They were often labeled as bath salts, plant food, pond water cleaner, and crucially marked not for human consumption. This was purely a cynical ploy by manufacturers to try and skirt drug laws and law enforcement detection.
And I remember a big problem for hospitals was that these didn't show up on standard drug tests.
That's a critical point for clinical practice. Because their chemical structures are so different from traditional drugs of abuse, they are not easily detected in standard urine toxicology screens.
Yeah.
This means clinicians are often flying blind initially, trying to manage a severely agitated or psychotic patient without knowing exactly what they took.
So pharmacologically, what are these synthetic cathinones doing?
They're nasty because they often act as powerful hybrids. Many of them both increase the release of catecholamines, like amphetamines do, and they inhibit the reuptake, like cocaine does. So you get this combined, often very intense and unpredictable stimulant effect.
What does that look like clinically? What's the presentation?
Usually a very rapid onset of intense amphetamine-like stimulation, but often coupled with significant sympathomimimetic effects, meaning effects that mimic psychosis.
Psychosis, like hallucinations.
Yes, extreme hallucinations, paranoia, severe agitation, often described as excited delirium, psychotic reactions. The greatest dangers include these psychiatric emergencies, along with convulsions, hyperthermia again, acute kidney injury, often from rhabdomyolysis, which is muscle breakdown due to the extreme agitation, and unfortunately, deaths have been widely reported. They're among the most unpredictable and dangerous substances we encounter.
That's a disturbing picture.
Okay, that seems like a logical transition point then. From stimulants mimicking psychosis to Section 2, hallucinogens, agents specifically known for altering perception and consciousness. Where better to start than the classic psychedelic, LSD?
Lysergic acid diethylamide, LSD. First created, actually synthesized from ergot, a fungus that grows on rye, back in 1938 by Albert Hofmann. Its characteristic psychedelic effects are primarily mediated by acting as a potent partial agonist at a specific type of serotonin receptor in the brain, the 5-HT2A receptor.
5-HT2A, okay,
Yeah.
and activating that receptor leads
It's
to...
the classic effects.
Yeah.
Vivid, often colorful hallucinations, significant alterations in mood, could be euphoria, could be anxiety disturbances in sleep patterns, and sometimes profound anxiety or paranoia.
One of the striking things about LSD is how quickly tolerance develops, isn't it?
It's remarkably rapid. Often after just a few consecutive days of use, the effects diminish significantly. This happens pharmacologically through the downregulation of those target 5-HT2A serotonin receptors. The brain basically becomes less sensitive to the drug. What about physical side effects? Is LSD physically dangerous in the same way as stimulants?
Generally, no. The direct physical adverse effects are usually quite minimal. You might see some mydriasis, dilated pupils, maybe a slight increase in heart rate, blood pressure, or body temperature, but usually nothing severe.
So if the physical toxicity is relatively low, where does the real danger with LSD lie?
The toxicity is almost entirely behavioral or psychological. The most troubling effects stem from the profound loss of judgment and the severely impaired reasoning that can occur during the trip.
The bad trip.
Exactly. That loss of cognitive control can escalate into extreme panic, paranoia, the feeling of losing one's mind. And that state is what often leads the user to sustain accidental traumatic injury, maybe through falls, jumping from heights, walking into traffic, or other irrational, dangerous actions taken while judgment is impaired.
And as we've seen in pretty much every category so far, the danger profile gets worse with modern substitutions, right?
Unfortunately, yes. In recent years, Highly potent synthetic serotonin agonists, often referred to collectively as N-bomb compounds, like 25I-NBOM, have been synthesized and sold, often misrepresented as LSD on blotter paper or in liquid form.
And these N-bombs are more dangerous.
Much more dangerous physically. Unlike LSD, these N-bomb compounds have been associated with far more severe toxicity, including dangerous hypertension, seizures, significant hyperthermia, and tragically, accidental traumatic injuries and deaths resulting from severely altered mental states. So again, the illicit market evolves, replacing a relatively physically benign drug with something far riskier.
Okay, let's move on to probably the most widely used substance in this section, and maybe overall illicitly, marijuana or cannabis. It has an incredibly long history, doesn't it?
Indeed. Evidence suggests humans have been using cannabis for well over 10,000 years for various purposes.
Hmm.
And today, yes, it remains the most frequently used illicit drug globally, and it's often the first illicit drug that new users try.
The pharmacology really centers on one main psychoactive compound, right?
That's right. The main psychoactive alkaloid is a delta-9-dinotetrahydrocannabinol, better known as THC. And here's a absolutely critical fact for understanding modern cannabis use. Due to decades of selective breeding, advanced cultivation techniques, the concentration of THC in the plant material available today has skyrocketed.
Skyrocketed how much?
We're talking increases of up to 20-fold, maybe even more in some concentrates, compared to the cannabis commonly available, say, 50 years ago. This is simply not the same drug your parents might have encountered. It's dramatically more potent.
And this high-potency THC primarily works by activating specific receptors in the brain.
Yes, it activates the cannabinoid CB1 receptors, which are widely distributed throughout the brain and body.
Okay, so activating CB1 receptors leads to what kinds of effects?
You get the effects most people associate with cannabis: euphoria, often followed by drowsiness, a sense of physical relaxation, hyperphagia, that's the intense desire to eat, the munchies, an increased heart rate, decreased muscle coordination, and often conjunctivitis or red eyes due to vasodilation. There can also be some minor pain control effects.
What about the sensory and cognitive effects?
Sensorily, THC stimulates the amygdala, which can enhance sensory perception. Music might sound richer, colors seem brighter, and it contributes to that characteristic feeling of novelty, where familiar things seem new or interesting again.
But cognitively, there are downsides, especially for younger users.
Definitely. THC affects the function of GABA, an inhibitory neurotransmitter, particularly in the hippocampus, which is a brain region crucial for learning and memory formation. This leads to a noticeable diminishing of short-term memory capacity.
Forgetting things mid-sentence.
That kind of thing, yes. And this effect seems particularly pronounced and potentially more long-lasting in adolescents whose brains are still actively developing. It also clearly decreases muscle strength and significantly impairs highly skilled motor activity, which is why driving under the influence of cannabis is dangerous and illegal.
Let's talk about tolerance and dependence. You mentioned a unique sort of paradox related to boredom.
Right. Tolerance to cannabis, especially with frequent, heavy use of high-potency products, develops quite rapidly. What happens pharmacologically is that those CB1 receptors get downregulated. The brain reduces their number or sensitivity to try and compensate for the constant stimulation.
Okay, so the brain adapts.
It adapts. Now, for heavy chronic users, when they stop using the drug, the absence of that THC stimulation combined with the reduced number of sensitive CB1 receptors can leave them feeling, well, bored, apathetic, lacking motivation. Things just don't seem as interesting or rewarding.
And that feeling becomes a driver to use again.
Exactly. It acts as a form of negative reinforcement, pushing them back towards using the drug just to feel normal or engaged again. As for dependence, estimates suggest about 9% of all cannabis users develop dependence, but critically that number jumps significantly to around 17% for those who start using heavily during adolescence.
Now, withdrawal from cannabis, unlike the rapid, intense crash from cocaine, it seems to be often delayed. Why is that?
That's a key difference related to its pharmacokinetics. THC is highly lipophilic, meaning it loves fat. It gets stored extensively in the body's fat tissues.
Oh, it lingers.
It lingers for a long time. In heavy, chronic users, THC and its metabolites can be detected in urine for weeks, sometimes even up to 3 months after they last used. Because of this very long elimination half-life, the withdrawal symptoms.
What are the typical withdrawal symptoms?
They usually include things like cravings, insomnia, or disturbed sleep, irritability, anxiety, decreased appetite, maybe some physical discomfort or pain. But because the drug leaves the body so slowly, These symptoms often don't appear until days or even weeks after cessation, which is much later than withdrawal from drugs like alcohol or opioids that are cleared more quickly.
That's interesting. Before we leave cannabis, we really should touch on its medicinal uses, as this is a huge area of research and policy change globally.
Absolutely. Cannabis, or its specific components like THC and CBD, cannabidiol, are increasingly used medically, often as an adjuvant, meaning a supplemental treatment alongside other therapies.
For what kinds of conditions?
The list is growing, but established uses include managing chemotherapy-induced nausea and vomiting, or CINV, also for cachexia, which is that severe wasting syndrome you see in some cancer or AIDS patients, helping stimulate appetite. It's used for certain types of epilepsy, particularly childhood seizure disorders. Also for chronic pain, reducing spasticity and multiple sclerosis, managing glaucoma, and sometimes for anxiety.
And there are actual prescription products derived from cannabis now, aren't there?
Yes, we have synthetic prescription versions like dronabinol and nabilone, which are basically oral forms of THC approved primarily for CINV. And then there's nabiximols, which is an oral spray containing both THC and CBD, derived directly from the plant that's approved in several countries, though not yet the U.S., for treating spasticity in MSN. This really highlights the important pharmacological distinction between using the whole, often high THC recreational substance and the targeted medicinal application of specific cannabinoids.
Okay, good distinction. Let's briefly wrap up this hallucinogens section with the synthetic cannabinoids, often known as spice, or K2.
Right. These are quite different from natural cannabis. They are typically synthetic chemicals, often highly potent chemicals, that are sprayed onto dried plant material, sometimes just inert herbs. This process is called dusting. Users then smoke this plant material.
And the big issue here, similar to the bath salts, is avoiding detection.
Exactly. Because their molecular structures are often completely different from natural THC, users won't test positive for marijuana on standard drug tests. This was a major part of their initial appeal, especially for people subject to drug testing, and it makes monitoring and enforcement very challenging.
But pharmacologically and in terms of toxicity, they're much worse than natural cannabis.
Both significantly more dangerous and unpredictable. While natural cannabis can increase heart rate, these synthetics frequently cause severe sympathomimetic effects, profound tachycardia, dangerous hypertension. But the greatest danger really lies in the potential for extreme hallucinations, severe psychotic reactions, intense agitation, convulsions, acute kidney injury, and, tragically, deaths have been well documented, often linked to newer, even more potent formulations or contaminants introduced during illicit manufacturing. They are far riskier than THC.
That paints a very clear picture of increasing danger with synthetics. Okay, that sets us up perfectly for a really massive topic. Section 3, ethanol or alcohol. Quantitatively, this is the most commonly abused substance on the planet.
Without a doubt, its impact is enormous. It's a depressant, and its scale of misuse is frankly staggering, deeply woven into the social fabric of many cultures.
And the consequences are devastating.
Absolutely.
Yeah.
It's tragically linked to a huge number of deadly car accidents, drownings, falls, violence. The prevalence of alcohol use disorder is estimated to be as high as 12.6% in the general population in some studies. And we know that chronic, heavy abuse slashes an individual's life expectancy by, on average, 10 to 15 years. This affects millions and millions of families.
Mechanistically, what is ethanol actually doing in the central nervous system to cause such widespread effects?
Ethanol is classified as a general CNS depressant, but its effects are very much dose-dependent. At low doses, say 1 or 2 drinks, it can act as a selective depressant. It tends to depress inhibitory control centers in the brain first.
Which is why people often seem more outgoing or talkative initially.
Exactly. That decreased inhibition can lead to loquaciousness, sometimes seemingly stimulated behavior, even though it's fundamentally a depressant effect. But as the dose increases, it becomes a general CNS depressant.
Affecting more brain functions.
Yes, leading to progressively impaired motor function, slurred speech, poor judgment, sedation, and at high enough doses, it risks coma and, crucially, life-threatening respiratory depression, stopping breathing.
What's the underlying pharmacology driving these effects?
It's complex and involves multiple neurotransmitter systems. Primarily, ethanol enhances the effects of the brain's main inhibitory neurotransmitter, GABA, specifically at GABA-A receptors. This calms neuronal activity. It also increases the release of endogenous opioids, contributing to reinforcing effects. And it alters levels of other key neurotransmitters like serotonin and dopamine, further contributing to its complex effects on mood and behavior.
Okay, let's talk about how the body handles it, the pharmacokinetics. Absorption seems pretty quick, but variable.
Yes, ethanol is absorbed rapidly, mostly from the stomach and the duodenum, the first part of the small intestine. However, the rate of absorption can be significantly slowed down if there's food in the stomach, particularly fatty food.
So drinking on an empty stomach leads to faster intoxication.
Much faster. Peak blood alcohol levels are usually reached within about 20 minutes, up to maybe an hour after the last drink, depending on various factors. And here's a really crucial clinical insight, something you might notice socially too.
What's that?
The subjective feeling of intoxication, how drunk someone feels, is often greater while their blood alcohol level is ascending while it's still going up during the absorption phase.
Compared to when it's going down.
Exactly.
Yeah.
Compared to when their level is descending, even if the actual blood alcohol concentration, BAC, is the same or even slightly higher on the way down. So someone might start to feel a bit less drunk as their body actively clears the alcohol, even if their BAC is still well above the legal limit. This can lead to dangerous misjudgments about their fitness to drive, for instance.
That's a really important point. Now let's get to the metabolism pathway. You mentioned this is arguably the single most critical pharmacological feature of ethanol.
It absolutely is. It dictates everything from how long intoxication lasts to how we treat dependence. Ethanol is metabolized almost entirely by the liver through unique two-step enzymatic process.
Okay, step one.
Step 1. The enzyme alcohol dehydrogenase, or ADH, converts ethanol into a substance called acetaldehyde.
Acetaldehyde, is that harmful?
Very harmful. Acetaldehyde is a highly toxic compound responsible for many of the unpleasant effects like flushing and nausea, and it's a known carcinogen, so the body needs to get rid of it quickly.
Which brings us to step two.
Step 2. Another enzyme, aldehyde dehydrogenase, or ALDH, rapidly converts that toxic acetaldehyde into a much less harmful substance called acetate, which the body can then easily use for energy or eliminate.
Ethanol to acetaldehyde via ADH, then acetaldehyde to acetate via ALDH. Got it. And this pathway has a very specific characteristic regarding its speed, right? The zero-order elimination.
This is the absolute mastery piece for ethanol pharmacology. Unlike almost all other drugs, which are typically cleared via first-order kinetics, where a constant percentage of the drug is cleared per unit of time, ethanol is metabolized via zero-order elimination, meaning the body eliminates a constant fixed amount of alcohol per hour, regardless of how much alcohol is actually in the system. The enzymes, primarily ADH, become saturated even at relatively low concentrations.
So there's a fixed speed limit for clearing alcohol?
Exactly. The rate is typically somewhere between 15 to 40 milligrams per deciliter per hour, mg/dlh, depending on the individual's genetics, liver health, etc. But for any given individual, it's a roughly constant rate. This is why fundamentally time is the only real antidote for alcohol intoxication.
No amount of coffee or cold showers will speed up those enzymes.
Nope. Coffee might make you a wide-awake drunk, but it won't make you sober any faster. You can't push that enzymatic pathway any harder than its maximum rate. It just moves at its own fixed pace until the alcohol is gone.
And this fixed rate, this predictability, is also the basis for legal enforcement using breathalyzers.
Precisely. Because there's a relatively constant ratio between the concentration of alcohol in the blood and the concentration in exhaled breath, roughly 2100 to 1 4 breath. A breath sample can be used to accurately estimate the blood alcohol concentration, BAC.
Okay. What about managing acute alcohol toxicity in the ER? Someone comes in severely intoxicated.
Treatment is primarily symptomatic and supportive, monitoring breathing, heart rate, blood pressure, preventing aspiration if they're vomiting. Critically, we administer thiamine, vitamin B1, and usually folate.
Why thiamine?
To prevent Wernicke-Korsakoff syndrome, a serious neurological disorder caused by thiamine deficiency, which is extremely common in people with chronic alcoholism due to poor nutrition and alcohol's effect on absorption. Giving thiamine, especially before any glucose-containing IV fluids, is standard of care.
Can you dialyze alcohol out?
Technically, yes, dialysis can remove ethanol from the blood. But it's very rarely necessary, usually only considered for extremely high, potentially lethal levels, often in combination with other toxic alcohol ingestions like methanol or ethylene glycol. And performing dialysis on someone who is physically dependent on alcohol carries the significant risk of precipitating severe, acute withdrawal right there on the dialysis machine. So it's generally avoided for uncomplicated ethanol intoxication.
Right. Now, chronic abuse. The damage is just devastating, isn't it? Across multiple organ systems.
It's profound. We see severe hepatic damage, fatty liver, alcoholic hepatitis, eventually cirrhosis, cardiovascular problems, hypertension, cardiomyopathy, arrhythmias, pulmonary issues, increased risk of infections, hematologic problems affecting blood cells, endocrine and metabolic disturbances, and of course profound and often permanent damage to the central and peripheral nervous systems.
But the most immediate life-threatening situation related to chronic use isn't the long-term damage, it's the acute withdrawal, right?
Absolutely. Alcohol withdrawal, which occurs when someone who is physically dependent suddenly stops or drastically reduces their drinking, is a true medical emergency. This is a key distinction. Unlike withdrawal from opioids, which is miserable but typically not fatal,
Yeah.
alcohol withdrawal can kill you if not managed properly.
Why is it so dangerous? What's happening physiologically?
Remember how alcohol enhances the inhibitory effects of GABA? Well, with chronic use, the brain adapts by downregulating GABA receptors and upregulating excitatory systems, like those using glutamate, to maintain a balance. When you suddenly remove the alcohol, you lose that enhanced GABA inhibition, and you're left with an unopposed, hyperexcitable state.
So the brain goes into overdrive.
Exactly. It's a state of severe CNS hyperexcitability. This manifests clinically as tachycardia, profuse sweating, tremors, the shakes, intense anxiety and agitation, sometimes visual or auditory hallucinations, alcoholic hallucinosis, and most dangerously, generalized tonic-clonic seizures, also known as grand mal convulsions. Severe withdrawal can progress to delirium tremens, DTs, characterized by profound confusion, disorientation, autonomic instability, and a high mortality rate if untreated.
And this is where benzodiazepines become absolutely critical again, but for a completely different reason than with cocaine toxicity.
Yes, this is an absolutely essential distinction for mastery. In acute alcohol withdrawal, benzodiazepines like lorazepam, diazepam, chlordiazepoxide are administered aggressively, often using symptom-triggered protocols and titrated to achieve sedation. Their primary life-saving role here is to substitute for alcohol's effect at the GABA receptor, thereby calming the hyperexcitable CNS and, crucially, preventing and treating those potentially fatal withdrawal seizures.
So for cocaine, benzos calm agitation and help cool. For alcohol withdrawal, they prevent seizures.
That's the core difference in their primary life-saving function in these two contexts. It's vital to understand why you're giving the same class of drug for two very different underlying reasons.
Okay, that's very clear. Let's shift now to the long-term treatment of alcohol dependence itself, the pharmacotherapy options used alongside essential supportive psychotherapy. There are three main agents mentioned, starting with disulfiram.
Disulfiram, brand name Antabuse. This is a classic medication that works by creating a conditioned avoidance response. Pharmacologically, it works by irreversibly inhibiting the second enzyme in the alcohol metabolism pathway, ALDH, aldehyde dehydrogenase.
The enzyme that breaks down the toxic acetaldehyde.
Exactly. So if a patient taking disulfiram consumes even a small amount of alcohol, they can't break down the acetaldehyde effectively. It rapidly accumulates in their body.
And that causes?
It causes a highly unpleasant, sometimes dangerous, physical reaction. Intense facial flushing, throbbing headache, nausea, violent vomiting, sweating, hyperventilation, tachycardia, chest pain. Basically, feeling absolutely dreadful. The idea is that the patient takes the pill daily to prevent themselves from drinking because they know the consequence of mixing the two is physical misery.
So it relies on the patient's motivation to avoid that reaction.
Very much so. Compliance can be an issue, and it requires careful patient selection and education.
Okay, the second drug is naltrexone.
Naltrexone. This is a competitive, long-acting opioid antagonist. It works differently from disulfiram. It's thought to decrease the craving for alcohol and reduce the rewarding effects if someone does slip up and drink.
How does blocking opioid receptors affect alcohol craving?
Well, remember, we said alcohol increases the release of endogenous opioids. Naltrexone blocks the receptors these opioids act on, particularly in the brain's reward pathways. By blocking that opioid-mediated reward, it seems to dampen the urge to drink and makes drinking less pleasurable if it occurs. It's generally much better tolerated than disulfiram because it doesn't cause that acutely aversive reaction if alcohol is consumed. It helps the individual abstain without that constant, intense biological pull.
Makes sense. And the third agent is acamprosate.
Acamprosate. This is another medication aimed at reducing cravings and maintaining abstinence, but it works through yet another mechanism. It's thought to help stabilize the balance between inhibitory, GABA, and excitatory glutamate neurotransmission in the brain, which gets disrupted by chronic alcohol use and withdrawal. Specifically, it seems to modulate NMDA receptor activity, reducing the glutamatergic hyperexcitability associated with protracted withdrawal.
So, three different drugs, three different mechanisms targeting alcohol dependence.
Exactly. Disulfiram aversion, naltrexone, reducing reward craving via opioid antagonism, and acamprosate, reducing craving via glutamate modulation. And the absolute key takeaway here, which cannot be stressed enough,
Is that these medications don't work in isolation.
precisely. None of these pharmacological agents are magic bullets. They are most effective and really should only be used in conjunction with robust supportive psychotherapy and comprehensive psychosocial support programs. They help manage the biological aspects, but the underlying behavioral, psychological, and social drivers of the addiction must be addressed concurrently.
Okay, that's a comprehensive look at ethanol. Let's move into our final major area. Section 4, the prescription drug epidemic. This really focuses on the catastrophic rise and, importantly, the evolution of opioid misuse, particularly in the US, but also affecting parts of Europe.
Yes, this crisis has fundamentally reshaped the landscape of public health, addiction medicine, and even law enforcement over the past couple of decades. The statistics are just horrifying, and they really mark a period of significant public health failure, driven by a complex interplay of factors.
What kind of numbers are we talking about?
Well, the source material highlights a staggering 600% increase in the prescribing of opioid painkillers just between 1997 and 2007. Think about that, a six-fold increase in a decade.
That's unbelievable.
It gets worse. By 2010, the sheer volume of opioid pain relievers being sold in the U.S. was enough to medicate every single American adult around the clock with 5 milligrams of hydrocodone every 4 hours for an entire month.
How on earth did the medical system allow that level of prescribing to happen?
It was really a perfect storm. There was a major push, starting in the late 90s, often well-intentioned, to treat pain more aggressively. The concept of pain as the fifth vital sign emerged, pressuring clinicians to eliminate pain, often measured by simple pain scores.
So pressure to prescribe.
Intense pressure. This was coupled with an often exaggerated belief, heavily promoted by pharmaceutical companies, in the efficacy and safety of new, long-acting opioid formulations like OxyContin. There was a dangerous minimization of their inherent toxicity and particularly their massive addictive potential.
And this minimization happened among both doctors and the public.
Yes, many health professionals were led to believe these newer formulations were less addictive, and the public often perceived prescription drugs as inherently safe because they came from a doctor, unlike street drugs. This combination created fertile ground for widespread overprescribing and subsequent diversion and misuse.
Now, eventually, efforts were made to curb this prescription misuse, things like prescription drug monitoring programs, cracking down on pill mills, developing abuse-deterrent formulations of pills.
Right. Necessary steps, but they had an immediate and tragic unintended consequence.
Which,
As prescription opioids became harder to obtain or misuse orally, a vast population of individuals who had become dependent shifted towards cheaper, more readily available, and often more potent illicit opioids on the street, primarily heroin.
so closing one door pushed people towards another, arguably more dangerous one.
Precisely. And that initiated the next, even deadlier phase of the crisis, the fentanyl shift.
For fentanyl.
Yes. Heroin itself is dangerous enough, but starting around 2013-2014, the illicit drug supply became increasingly contaminated and then outright replaced with clandestinely manufactured fentanyl. And critically, not just fentanyl, but also its even more potent chemical analogs or derivatives.
Like carfentanil?
Exactly. Carfentanil is probably the most notorious example. To put the potency in perspective, heroin is roughly twice as potent as morphine. Fentanyl is estimated to be 50 to 100 times more potent than morphine.
But Carfentanil is estimated to be 10,000 times more potent than morphine.
1,000 times. That's unimaginable. It's an elephant tranquilizer. It was developed as an anesthetic for very large animals. A minuscule amount, literally the size of a few grains of salt, can be lethal to a human. And this, or substances like it, started flooding the illicit opioid market, often mixed into heroin or pressed into counterfeit pills made to look like prescription oxycodone or Xanax.
And this is where the pharmacology directly leads to catastrophe, driving those unprecedented overdose mortality statistics we've seen.
Absolutely. The pharmacological challenge presented by these ultra-potent synthetic opioids is immense. Because of their extreme potency, fentanyl and its derivatives bind incredibly tightly to the opioid receptors in the brain, particularly the mu-opioid receptor responsible for respiratory depression.
They bind more tightly than older opioids like morphine or heroin.
Much more tightly and often more rapidly. This means that reversing an overdose caused by these synthetic opioids is dramatically more difficult than reversing an overdose from, say, heroin alone.
What does that mean practically for first responders or in the ER when someone overdoses? You use naloxone, the opioid antagonist, right?
Yes, naloxone Narcan is the antidote. It works by competitively blocking the opioid receptor. But against fentanyl, and especially carfentanil, the standard doses of naloxone that were effective for heroin overdoses often fail entirely,
They just don't work.
or they only work very briefly. Because the fentanyl binds so tightly, you need much higher concentrations of naloxone to displace it from the receptor. Patients overdosing on fentanyl or its analogs frequently require significantly higher doses, often repeated doses, sometimes even continuous intravenous infusions of naloxone to maintain breathing.
Because the fentanyl lasts longer than naloxone.
Often, yes. The duration of action of naloxone can be shorter than the duration of respiratory depression caused by these potent, long-acting synthetics. So you can reverse them initially, but then they slip back into respiratory arrest as the naloxone wears off. This potency and the difficulty in reversal directly fueled the dramatic surge in overdose deaths, which exceeded 33,000 opioid-related fatalities in the U.S. back in 2015 alone, a number that sadly continued to climb as these synthetics became even more prevalent.
And the shift from primarily oral prescription misuse to injected heroin and fentanyl has broader public health consequences too, doesn't it? Beyond just overdose risk.
Absolutely. The increase in injection drug use directly led to outbreaks and increased transmission rates of infectious diseases like HIV and particularly hepatitis C, placing further immense strain on the healthcare system and creating long-term health burdens for the affected population. So understanding the sheer potency difference, the binding affinity, and the resulting need for immediate, aggressive, high-dose reversal strategies is really the key clinical takeaway for mastering this devastating stage of the opioid epidemic.
Okay, wow. So we've really covered a huge amount of ground here, from the stimulating rush of cocaine driven by that reuptake inhibition to the, profound cognitive and perceptual shifts from CB1 activation by high-potency THC, the unique systemic impact of ethanol zero-order elimination, and finally this constantly evolving, incredibly dangerous crisis of synthetic opioid pharmacology.
We certainly have. We've detailed quite a few diverse mechanisms, haven't we? Reuptake inhibition with cocaine, enhanced neurotransmitter release with amphetamines, the specific CB1 receptor activation for cannabis, that crucial GABA enhancement characterizing depressants like alcohol, and the potent opioid receptor agonism driving the opioid crisis.
So what does this all mean? If you're trying to achieve mastery in this professional field, what's the through line? We've seen that the road to addiction and toxicity is really mapped out by these specific, profound chemical mechanisms, right? From that rapid cocaine crash driving immediate reuse to the unique pharmacokinetic pathway of ethanol that dictates sobriety is just a matter of time, not willpower.
That's exactly it. The mastery, the elite professional understanding, truly lies in connecting those specific pharmacological details, the receptor interactions, the metabolic pathways, the half-lives directly to the necessary clinical interventions, and the observed patient outcomes.
Can you give an example of that connection?
Sure. Understanding why benzodiazepines are essential for calming agitation and managing hyperthermia in cocaine toxicity, partly by halting that excess muscle heat generation, is fundamentally different from understanding why they are the absolute cornerstone for preventing potentially fatal seizures in acute alcohol withdrawal by substituting for alcohol at the GABA receptor.
Same drug class, different primary life-saving mechanism based on the underlying pharmacology of the toxicity or withdrawal state.
Precisely. Grasping those nuances is what separates basic foundational knowledge from true, elite professional practice and understanding. It allows you to anticipate problems, tailor treatments, and explain outcomes effectively.
And it seems the most urgent, the most rapidly evolving challenge right now comes from that constant chemical innovation within the illicit supply chain.
Without a doubt. We spent some time detailing the extreme potency of modern synthetic opioids like carfentanil, where reversal requires, orders of magnitude more naloxone than for traditional opioids. Given the incredible speed at which illicit chemists synthesize new, even more potent drugs, often specifically designed to evade detection and maximize profit. The really crucial question, the provocative thought maybe for you, our listener, to consider is this.
Okay, what should we be thinking about?
How does this rapid, relentless evolution of illicit chemistry fundamentally challenge our current pharmacological and public health strategies? Strategies designed to manage toxicity, prevent addiction, and save lives. Especially when our existing pharmacological antidotes, like naloxone, struggle to keep pace with the sheer novelty and overwhelming power of the poisons we increasingly face. That ongoing, evolving chemical arms race, that is the pharmacological battlefield we must constantly prepare for and adapt to.